And I'm very pleased to present Maura Gillison, that she's going to provide the keynote to speak for this session, and she's going to talk about HPV in head and neck cancer. Thank you.
Thank you very much. I'd like to thank the organizers for inviting me to talk, and in particular, I've been going to HPV meetings for quite some time, and this is the first one where there's a major session on head and neck cancer, which I'm thrilled about. As they're preparing the slides, I'm happy to talk about a cancer that, like cervical cancer, is, okay. I don't know if they reach high enough. There we go. I'm happy to talk about a cancer that, like cervical cancer, is a major cause of morbidity and mortality worldwide. Unfortunately, there are about 600,000 cases in known cancer registries diagnosed each year, and about half of the individuals diagnosed with this cancer will die from it. Head and neck cancer, and here we see incidence rates for mouth and pharynx cancer. Incidence rates vary considerably by geographic site, and that's because the majority of the risk factors for head and neck cancer are related to cultural influences with regard to alcohol use, tobacco use, poor oral hygiene, and diet. There are very few non-modifiable risk factors such as family history, age, gender, and race. And on the basis of a lot of epidemiologic and molecular work done over a period of about 15 years, a review of the evidence linking HPV to head and neck cancer was published by IARC in 2007, where at that time they declared that there was sufficient evidence that HPV-16 is a cause of, in particular, oropharynx cancer and perhaps oral cavity cancer as well. And since 2007, since the causal association between HPV and oropharynx cancer and head and neck cancer has been established, the field now is really focusing on what does this mean in terms of potential for intervening into the disease process. And we really have the cervical cancer and the wonderful literature on cervical cancer and HPV to serve as a framework for us in the field of head and neck with regard to trying to intervene into the disease process with regard to primary and secondary prevention. So this is what the field is really focusing on now, and a lot of the abstracts that were selected for presentation today will address different aspects of this natural history and intervention. But what I'd really like to focus on in my talk is the important and complicated relationship between HPV and what remains the major cause of head and neck cancer worldwide, that is tobacco exposure. And I'd like to really touch on different aspects of the natural history of the disease and what we know today about that relationship between HPV and smoking and how that can affect our research and our outcomes and things that we need to take into consideration. In particular, I'll talk about smoking and its impact on oral HPV infection, and therefore smoking and its impact on our measures of HPV attributable fraction. I'll also talk about the complicated relationship between smoking, HPV, and risk of head and neck cancer, and also a relationship between HPV, smoking, and tobacco exposure and prognosis of head and neck cancer, and then also the complicated factors with regard to HPV and smoking and how that drives incidence trends. So I did this intentionally trying to figure out a way to talk briefly about these different aspects in natural history, but with an overlying uniform theme. So we learned a lot about the prevalence of oral HPV infection from a study that we did in the United States, which is the first population-based study of oral HPV infection. And this was done in NHANES with a goal to evaluate demographic and behavioral associations with oral HPV infection and also to get a good estimate of oral HPV infection prevalence. And we found that oral HPV infection was present in approximately 7% of the US population And when we looked at prevalence by age in years, we saw very different patterns from what we see in the cervical literature, and we've seen these curves in other discussions at this meeting. But again, I'm focusing on the relationship between smoking and oral HPV infection. And as you can see, the prevalence of oral HPV infection is dramatically affected by current smoking and the intensity of current smoking. So as you can see, when you look overall, a person who is smoking 1 pack of cigarettes per day currently, well, that group of individuals will have a prevalence of oral HPV infection that's not trivial, 1 in 5 or 20%. And what's interesting is there's a significant interaction between gender and smoking with regard to oral HPV infection. The current hypothesis is that there's probably a difference in immune response to oral HPV infection by gender, or the difference in seroconversion rates between men and women may confer protection for women that is not seen in men. So it's interesting to look at this difference with regard to the interaction between smoking and gender and oral HPV infection, because if it is an immune suppressant, it appears that smoking among women has a greater effect with regard to oral HPV infection prevalence than for men. So this is a consistent association now seen in prevalence studies, along with gender, age, sexual behavior, HIV infection, and severity of immunosuppression. And we'll learn a little bit more about that in one of the speakers today. But current smoking is consistently associated with oral HPV infection prevalence, and we'll also learn that it might affect both incidence and persistence of infection. Now, we've seen the impact of this in our own estimates of the prevalence of HPV infection in oral cancers. In our work recently, we published 430 consecutive cases of oral cavity cancer, and we had 409 that were evaluable for RNA expression. By DNA, we found 9.8% were HPV DNA positive, but by RNA E6, E7, we found only 5.9% were positive. Now, when we looked at the samples that were positive by RNA expression, we saw P16 positivity, positivity by in situ, high viral load, all the things that correlate with HPV causing a role. But for those HPV positive tumors that didn't have these patterns, we saw really low copy number. And I think what's really driving that, we talk about contamination in the laboratory, cross-contamination, et cetera. Well, it's really because the majority of people who are diagnosed with oral cavity cancer are 1 pack per day or more current smokers. So it really is the fact that these people probably have an oral HPV infection, but that it's not the driver of their cancer. And so we're seeing this internationally when we see estimates of oral HPV in oral cavity cancers of between 20 and 30%. And that's what I would expect to see given the relationship between oral HPV and current smoking. And we see in these oral cavity cancers that are E6 and E7 positive the same associations with male gender, poor differentiation, basaloid or verrucous histology, and early T stage. So the same things we see in oropharynx cancer, we're seeing in HPV positive oral cavity cancer. The other thing that I wanted to talk about is the impact of the relationship between HPV and current smoking and its effect on case control studies, looking at the association between HPV and risk of head and neck cancer. When we look with regard to behavioral associations that can be equally measured in cases and controls, we see that there are distinct risk factor behavior patterns in HPV positive and HPV negative head and neck cancer, and we see no evidence of an interaction or any evidence that tobacco use increases the risk of HPV positive head and neck cancer. But when you use other biomarkers of exposure to HPV, in particular, for instance, oral HPV infection, and also L1 serology, these relationships become a little bit more complicated. And we've seen in case control studies of cervical cancer in which individuals are trying to focus on identification of cofactors for cervical cancer by restricting the cases and controls to women with cervical HPV infection, that it's complicated to sort out the issues of confounding and from a cofactor, and in particular from mediators, because I think smoking is mediating the effects of HPV infection by promoting persistence of infection. The other thing that complicates the picture is it appears that smoking and current smoking among HPV-infected people may affect seroconversion rates. And we see different publications going in different directions in this regard, with smoking either increasing or decreasing rates of seroconversion in response to HPV infection. So obviously these are complicated and somewhat flawed biomarkers of exposure, and particularly complicated when you think of this in terms of smoking mediating the effects of HPV. The second to the last thing I wanted to talk about was the impact of smoking on prognosis of head and neck cancer. We've seen consistently over the last 3 or 4 years that HPV is a very strong predictor of survival of head and neck cancer, and we see consistently within clinical trials on biobanked specimens a strong relationship such that HPV-positive patients have at least 60% reduction in their risk of dying when compared to an HPV-negative patient. And this is pretty consistent from study to study, independent of how the patients are treated, independent of where in the world the study is done. We've done an analysis in radiation therapy oncology group clinical trials, and we see what everyone else is now seeing, a 60% or 70% reduction in risk, which translates to about a 30% absolute difference in survival at 5 years. And in recursive partitioning analysis, we've determined that HPV is the single greatest predictor of whether someone lives or dies after a diagnosis of oropharynx cancer, and when you include all the other head and neck cancers, it remains the case. But what we were interested to find is that the second most important determinant of whether a patient lives or dies, whether it's HPV positive or HPV negative head and neck cancer, is the cumulative amount of tobacco exposure that the individual had prior to their diagnosis of cancer, and also continued smoking through radiation therapy. So you can use HPV status and then smoking exposure, and then what we currently use for prognosis third is tumor stage. And you can use that to divide patients into those who are low risk, intermediate risk, and high risk for death from their malignancy. This was the study that we first investigated that relationship. We've now validated that in a second trial, demonstrating in different periods in calendar time with different treatment approaches. We see the same thing with regard to impact of smoking on survival, so that we see an estimated 1% increase in risk of death per pack year, or 2% increase in risk of death per year of continuous smoking, that appears to plateau somewhere between 30 and 40 pack years of exposure. So clearly, that's important, and my current thought on the matter is that as smoking is mediating the effects of HPV by promoting persistence of oral HPV infection, smoking is also doing what we know it to be doing, which is causing secondary genetic events and mutations such that an HPV-positive patient who has smoking exposure, the probability of getting that critical second, third, fourth genetic event, which will make the tumor respond to treatment more like an HPV-negative than an HPV-positive cancer, is a function of how much that person smoked. And we see evidence of this with regard to population-based survival estimates. This is data from SEER looking at the survival outcomes for HPV-positive and HPV-negative head and neck cancers in Iowa, Hawaii, and LA. This is the longest follow-up that I'm aware of in head and neck cancer patients, with a median follow-up of 112 months. And we see that that survival difference is sustained over time, so that the median survival is 131 months for the HPV positive patient versus only 20 months for the HPV negative patient. But what I found really interesting in this study is the period effects. When we looked at overall survival for oropharynx cancers by period, you see here on your x-axis median survival in months, and on the y-axis we're seeing different periods, and on the top is overall oropharynx cancer. And you see that in the US, the survival of oropharynx cancer improved over calendar time in the United States. But when you stratify that by HPV tumor status, you see, unfortunately, that HPV negative oropharynx cancer survival has not improved over time. And I don't think there's any reason to believe that changes in therapy would differentially affect HPV negative versus HPV positive oropharynx cancer over this period of time because we weren't really testing tumors until the last 3 years. But what's really interesting is for the HPV positive oropharynx patients, we thought, well, this improvement at the US population level is really being driven by an increasing proportion over time for HPV positive cancers. But among HPV positive cancers, we see that their survival is improving over calendar time as well. And I think this is probably being driven, if HPV tumor status is your #1 predictor of survival and tobacco exposure is your #2 predictor of survival, we know there have been significant population level changes with regard to tobacco exposure in the United States over calendar time. And this is a beautiful paper published in JAMA in 2011 showing the profound effects of age and period on smoking over 10 cigarettes per day and how that has changed significantly by birth cohort and calendar time. And then the last thing I wanted to talk about is how complicated it is to look at the effects, to look at incidence changes over calendar time and the effect on a period in which the tumor was collected on the estimates for the HPV etiologic fraction, because these things are in incredible flux. We're seeing from country to country significant changes in incidence trends for oropharynx cancer relative to oral cavity cancers and other head and neck cancers, with a number of countries around the world showing significant increases in the incidence of oropharynx cancer. And in 3 of those regions, Australia, Sweden, and the United States, HPV has been implicated as the cause of those incidence changes. Here we see data from Stockholm, Sweden, on the proportion of tonsillar cancers that were HPV positive by calendar time. And you see that the proportion is going up and incidence rates are going up for HPV positive tonsillar cancer in Sweden over calendar time, where by contrast, incidence rates for HPV negative tonsillar cancer are going down. And it's not difficult to see if you are trying to say, instead of this being one country over different periods, that these are actually different countries at the same time, you'll see that the etiologic fraction for HPV in this country would be markedly different for HPV in this country. And it's really being driven by the different relative rates of HPV positive and HPV negative cancer at that particular period. We see this also in the United States, where we see a significant 28% increase in incidence for oropharynx cancer over only a 16-year time period. But what we see underlying that is a 50% reduction in risk of HPV negative cancer at the same time, where we see a over 225% increase in incidence of HPV positive head and neck cancer. There are other regions of the world that have seen these same trends over time, but that has not been shown to be attributable to HPV, but you do get some interesting hints when you look at incidence changes in different countries and you compare that among men and women to incidence changes for other tobacco-caused cancers. And here, in a collaboration with Anil Chaturvedi and investigators at IARC, is an example of this, where we're looking at incidence trends for squamous cell carcinoma of the lung, which is largely driven by tobacco. And you see in multiple regions around the world where there is a significant increase in the incidence of oropharynx cancer among men, you see at the same time a significant decline in incidence rates for squamous cell carcinoma of the lung, consistent with the hypothesis that this is being driven by another factor. Whereas by comparison among women, you'll see that in the majority of the regions where you see an increase in incidence for oropharynx cancer, you also see significant increases in incidence for squamous cell carcinoma of the lung, consistent with those changes being driven by the fact that women are still, quote unquote, catching up to men in different regions of the world with regard to smoking and tobacco exposure. So in conclusion, there are complex interactions between smoking, HPV, with regard to the natural history of infection, risk of head and neck cancer, cancer prognosis, and incidence trends over time. Current smoking appears to increase prevalence, perhaps through both increased incidence and persistence of HPV infection. This complicates our analysis of interactions between HPV and smoking in case control studies. The association between smoking and HPV can affect estimates of the etiologic fraction based upon HPV DNA detection alone, and we're seeing that now in beautiful work presented here, that you can't use HPV DNA detection alone in that regard. And that's in large part not due to contamination in extremely careful laboratories like Xavier and his colleagues. It's really the infection is probably there in the patient, and it's there in the sample after you've collected it. The effect of smoking on HPV natural history could affect measurements of risk associated with HPV infection and serology, and could, to some extent, explain the confusing literature on those interactions. And then the relative rates of cancers driven by HPV and smoking will be driven by geographic heterogeneity in these exposures and the relative rates for incidence of two completely, perhaps, different cancers. So I just wanted to spend a little introduction, a little couple minutes as an introduction to the topics that will be addressed by our speakers. We have 8 of them, so it's going to be a little bit of a whirlwind. And to some extent, some of these questions will be addressed by these. But what I'm hoping is when I come to the next 3 HPV meetings and there's someone else other than me giving this plenary talk on head and neck cancer, I'm going to keep these slides and come back and see how much progress we're making on these questions. The important questions to the field. What is the molecular definition of an HPV-caused cancer? We've heard at this meeting that perhaps expression of E6 and E7 oncogenes is not enough. Role of HPV in non-oropharyngeal cancer. I think we'll see impressive work on that question. What is the true HPV attributable fraction worldwide? An important question with regard to the potential impact of HPV vaccines. What is the natural history of oral HPV infection? And as a clinician, in my mind, that data as an epidemiologist is very interesting, but as a clinician who treats HPV-positive head and neck cancer patients each year, the only significance to HPV natural history studies is the potential to get data that will allow us to intervene. Will HPV vaccines prevent oral HPV infection? Do we need clinical trials to demonstrate true efficacy in order to recommend HPV vaccination for prevention of this cancer? Or can we use just observational data and take it from there? Can oral HPV infection be used to screen individuals who are at risk for this cancer? How can we identify pre-malignant lesions so that we can intervene Is there a colposcopic equivalent? Why is HPV a prognostic factor? What are the underlying biological reasons driving that? And can they be used to alter therapies to identify pathways that we could potentially target for HPV negative head and neck cancers so that we can increase the effectiveness of chemotherapy and radiation? And is HPV status predictive of treatment response to any particular treatment? And can we use HPV status really to drive treatment and predict and improve survival, in particular in HPV positive smokers? So I didn't talk about my conflicts. I've been a consultant to Merck and GSK, so I always forget to do that, so I just want to say that. And then here are the thank yous to all of the individuals that I get to work with on a daily basis. Thank you.